countries, although it's a local conference for Pakistan, but this has people registered from different parts of the world. So, with the due permission from our chair of this session, Dr. Noreen Mushtaq, if I can start on this, Dr. Noreen, do you have your permission?
Yes, please, Dr. Adhir.
Thank you. So thank you very much, everyone, for joining us. This is the first symposium on the neuro-oncology in Pakistan. The question is, why do we need something like this in Pakistan, whereas we have so much neuro-oncology work and symposium and conferences going across the world? Well, the reason is, yes, it's true that the world is becoming a global village, and with the technology, we all feel so connected. But I think the problems are not homogeneous throughout the world. The problems are different in different parts of the world, and that needs to be taken into account. So there has to be a good networking among people. There has to be a good communication among the specialists across the world, but then it has to address the local problems as well. So for that, it's very important that there is an organization, there is a network, a local network of people that focus on the local problem. And this connects to the concept of global health. This connects to the concept of global surgery. And this connects to the concept of global oncology. And here we are talking about global neuro-oncology, because these problems that exist in an LMIC or an LIC are different than the problems that exist in a high-income country. And even in high-income countries, there are pockets that may have these similar problems. So it's not that the high-income countries don't have to deal with these problems. They have to deal with that problem in a different context, in a different setting. And the HIC can learn a lot from LMIC and LIC also. For example, in China, which has a very high GDP per capita, there are issues of patients reaching to the neurosurgical center, and they have to travel very long distances. So it's not a unique problem that exists for LMIC. It's just that more prevalent in the LMIC. So for that purpose, it was important that we organize ourselves in Pakistan. And for that purpose, we organized ourselves into Pakistan Society of Neuro-Oncology. And on that platform, this is the first Neuro-Oncology Symposium. When I started to work on that about a year ago, I realized, and this is true for anything that you want to do in life, you find that there are people who are already doing it. And that's when I found that the chair of this session, Dr. Noreen Mushtaq, and then we have another very prominent speaker, Dr. Eric Buffet, Professor Eric Buffet. They were already working on it. They had already made the connection. They had already started to work on the local aspects of LMIC. And while that was going on, I decided that we need to write a grant for training some clinician researchers in oncology. And that's when I was introduced to Professor Houston Warren in Fred Hutchinson Center. And I realized that he has already been spending most of his time and work in different parts of Africa. He's already working on these things. So it was sort of a wonderful opportunity for me, that I didn't have to invent anything. All I had to do was to just hold the hands of all these people who are already working on these things and go along with them. And that has basically been the most interesting and most rewarding part of this organization to coming to know all these people and to realize that what they are doing. So we have an excellent program of one annos, and I hope that the one will go into two, and then it will go into 100 plus. By that time, I won't be here, and I think none of you guys probably will be here who are listening to this, but this should go on, and this will be a historical, remarkable event, one annos. I was very humbled by the people that have uh, accepted the invitation to speak on this um, in this symposium, and the booklet gives all the details, so you can look at that. And I look forward to the participation of all of you. This event could not have been possible for the day and night work of people working in the background. And the person that is the most important person in this is Mr. Sharif Charania, who is like a genie, who is like a person who can do anything to do these things, full of energy. So he is one of the main person who has actually done this work. And obviously the organization committee that is part of it, the scientific committee chaired by Dr. Shehzad Shamim, uh, another neuro-oncologist, surgical neuro-oncologist, and the members of all that committee. And then we have um, neuro science interest group, young energetic people who are supporting us, and then surgery interest group, another young group of young people in AKU who are supporting us. Plus, we have been endorsed by a lot of societies, including this Society of Neuro-Oncology, which is a North American society. That's the biggest one. Then we have European Association of Neuro-Oncology. Then we have World Federation of Neuro-Oncology Societies. We have been endorsed by the Asian Society of Neuro-Oncology. We've been endorsed by Sub-Saharan Society of Neuro-Oncology, and then local societies like Indian Society of Neuro-Oncology. So there are a whole bunch of societies that are going to help us, and it's very important. The purpose of society is networking, and we are already seeing a networking at the local level and at the global level. So thank you very much for joining us, and we will start with our next speaker, which will be introduced by our moderator, Dr. Fahad. Thank you.
Thank you very much, Dr. Athar, for that introduction. We will now formally begin today's proceedings with our first presentation by Dr. Eric Buffet. Dr. Eric is a leading pediatric neuro-oncologist in the world and professor of pediatrics at the University of Toronto, Canada. He is also Garin Family Chair in Childhood Cancer Research and Section Head of Neuro-Oncology at the Hospital for Sick Children, Toronto. He is going to be presenting to us on the key principles in the management of childhood medulloblastoma. Dr. Eric, over to you.
Thank you. Thank you very much for your kind invitation, and I'm delighted to be here to be with you. I'm sorry that I'm not really physically with you, but I remember very well my trip to Pakistan 2 years ago, and I really enjoy every single minute of my stay. And my first word, I would like to congratulate you for this first meeting of the Pakistani Society of Pediatric, the Pakistan Society of Neuro-Oncology. And I want to say hello to all my friends, pediatricians and pediatric oncologists there, with whom we have regular interaction through our twinning program. And I'm not going to talk about twinning tonight, but I will take my first slide, which is a slide for pediatricians, just to remind people that this month of September is the month of childhood cancer awareness. And I try as much as I could to communicate with many people to have as many monuments as possible lit up in gold. And this is the CN Tower that was lit up in gold on September the 1st. And there will be many other monuments that will be lit up over the next few weeks. Just to say that we try to raise awareness for childhood cancer And it seems that it has a snowball effect, which is fantastic. So tonight, or tonight for me, this morning for you, I want to discuss with you the management of medulloblastoma. And rather than just to discuss a sort of textbook presentation, I want just to guide you or to show you what you should avoid or what are the issues that you may face in the management and that you should try to escape. Just to mention that the treatment of a child with a brain tumor, and I think the treatment of any brain tumor of any people at any age, but particularly a child, is really an art of oncology. And there is a very fine line between what we call a success and a catastrophic success. And so this is a reason I want just to drive with you through all the issues that you may face, you and your team, and how important it is to communicate between people who are involved in the care to make sure that everything that is done is right. So this is my dream of my wish, that you understand the main challenges in the management of medulloblastoma at the time of diagnosis, at the time of surgery, at the time of the radiation treatment, and at the time of chemotherapy. So for the one who have limited knowledge of medulloblastoma, this is the most common malignant tumor in children, brain tumor in children. And the data from high-income countries show that 20 to 25% of the patients present with metastatic disease, either bulky metastatic disease or cytological positivity of the CSF called M1. Medulloblastoma is always located in the posterior fossa, but I will show you that there are some variation between different types of medulloblastoma. Histologically, for many, many years, this was one single entity until people looked more carefully and described different entities. And there are 4 categories of medulloblastoma: the classic, the nodular desmoplastic, and the large cell are the most common form. The large cell is associated with more aggressive behavior, and the MBEN is a very, very specific medulloblastoma that we see in early infancy. And I will show you a case because I think this is a very important illustration of what you should do or not do at the time of diagnosis. As I say, for many years, medulloblastoma was one entity until 2005 to 2010, when people started just to do some more sophisticated molecular technique, including sequencing, and they identify different groups of medulloblastoma or different subgroups. And there are currently 4 main subgroups of medulloblastoma: the Wnt, the sonic hedgehog, the group 3 and the group 4, which are characterized by different demographics, different clinical feature, different genetic aspect, and different gene expression. I will not just stay too long here. You will have access to the slide. But as I said, at the time of diagnosis, if you have some experience, you can pick the subgroup by just looking at the scan. For example, this cerebellar medulloblastoma is probably and very certainly a sonic hedgehog. This one with very poor enhancement located in the fourth ventricle is a group 4, when this one in the same location with significant enhancement is likely a group 3. What is the management of medulloblastoma? So first, it's a surgical resection. And we know this since a long time ago. At the time, there was no knowledge of medulloblastoma, but one person and his patient has described extensively this entity, and this is a surgeon that has influenced the neurosurgery practice worldwide, Harvey Cushing. And Harvey Cushing published in the years 1920 to 1930, the first report of medulloblastoma, and he's a person who first used the term medulloblastoma to describe this tumor. And he operated a large number of patients, but reported that they all die. And by doing autopsy, you could see that they were dying of dissemination and progression, including also local relapses. So he decided to use radiation, but the first patient that he treated with radiation, he had no idea of the dose. And as you could see, he also experienced a number of side effects, including radiation necrosis. But with this, he learned that radiation could kill the cell or prevent local recurrence. So it's only 20 to 25 years later that the technique that is used today, called craniospinal radiation, was first reported by Edith Patterson from Manchester. And this has really laid the basis of the treatment that we still use today. And so this paper is a really seminal paper where she described the technique, how she drew the field of radiation, how she managed to put the patient in order to have a strict immobilization and no motion. And the technique is based on the same aspect today, despite the fact that we use different tools and different mobilization or immobilization device. And then the chemotherapy came later, nearly 20 years later, very slowly with different drugs, but it's now part of the management of medulloblastoma. So how do we decide how to treat and how to use which treatments? It's essentially based on the age, and the age is going to really influence whether we use radiation or no radiation in very young children, the extent of disease, whether the disease is metastatic or not, the extent of resection, whether the resection has been good or incomplete, and increasingly we use also other factors such as the histopathology, the biology, including the subgrouping that I mentioned. But still today, medulloblastoma for treatment purposes is essentially just grouped in two categories. It's a sort of dichotomy: average risk, when patients have a good resection and no metastatic disease, and high risk in all other situations. Now, when we look at low and middle income countries, there are some additional challenges that are not always considered in high income countries, such as late diagnosis, incomplete surgery or difficult surgery because of limited material, and the delay between surgery, radiation, chemotherapy, which can also affect a number of aspects of the treatment. Having said that, in high-income countries, we have seen a very significant improvement in survival over the years, and this slide illustrates the results seen in average risk patients since 1970, the early SIOP and RTOG-CCG clinical trial, and the most recent clinical trial conducted. And this short slide show you that the survival that we describe at sick kids with our population in a paper published 5 years ago, which shows that in average risk and high risk patients, the survival is in the range of 80, that's the event-free survival, in the range of 80 to 85%. Now, let's go to the challenges, and I will try to work and to speak in the perspective of low and middle income countries. So one issue with the diagnosis of medulloblastoma in low and middle income countries is the delayed diagnosis. And the question is this really a problem? In fact, there have been a lot of studies that have looked at this, and surprisingly, they have shown that the longer the time to the diagnosis, the better the outcome. You can see on this slide whether a patient has a metastatic tumor or local non-metastatic tumor. The patients who have a shorter time to diagnosis often have a poorer prognosis, suggesting that the biology is the main driver. of the outcome and not the delay in the diagnosis. So next aspect I wanted to mention is when a patient is seen for the first time at the time of diagnosis and an MRI scan or a CT scan is done. So often there is no discussion, no consultation between the team, and the spine is not done for a number of reasons, time or lack of knowledge, but this is a critical test. And I wanted to show you an example of a spine that was missed at the time of diagnosis and that was done after the surgery. And you can see that there is extensive, disease in the spine, or what I would call pseudo disease in the spine. And looking at this, you can see that it mimics really metastatic disease. On the axial scan, the report was calling this diffuse metastatic disease. This was not a child with medulloblastoma, this was a child with epenymoma. And when I saw this, I was very upset. This was when I started at Sick Kids nearly 20 years ago. And I was very upset that the child did not have a spine before surgery. And I say, I refuse to give this child craniospinal radiation. I repeated the scan 2 months after, and at that time, this extensive metastatic disease had disappeared. So I could do this because this was an epenymoma, which is a less aggressive disease. At least in this case, it was not aggressive. I knew from the histology as well. But it illustrates the fact that it is critical to do the spine when you suspect a medulloblastoma, to do the spine before surgery, because the risk is that you upgrade the staging of the patient and you quote metastatic disease and use higher dose of radiation, higher dose of chemotherapy when there is no need to do so. So the other example I wanted to show is something that I experienced in one of our twinning programs when they showed me this case. Not unfortunately at the time the child was a baby at 2 months. The baby had some irritability and was seen in a hospital and had an MRI scan that showed this picture of a lesion in the posterior fossa. And so this is really something which is typical of an entity called MBEN, medulloblastoma with extensive nodularity. And the patient had no treatment, and this is what happened. 3 months later, he was still alive, so the parents requested to have another scan. The tumor was still there, the ventricles were awful, the child was blind, but was still alive. And I was asked my opinion of what to do. And I say, I can only cry when I see this, because look at what we know of MBEN. This is the result of the German study where children with MBEN were treated with limited surgery and chemotherapy only. The survival is spectacular, close to 100%. But if you don't know, you don't know. And you miss the point that this child could have been treated successfully and cured, even with a limited biopsy of his tumor, he could have been successfully treated. So that's also something which needs to be addressed, is who is talking to and how do you connect with people who know the entity if you have no clear idea of what it is. Now let's talk about the surgery. What are the issue with surgery? Often when a child presents with medulloblastoma, he has some evidence of ventriculomegaly or hydrocephalus. And I've seen this in many places. I've seen this in Africa, in Asia. I've seen this in Europe and in North America as well. The child has hydrocephalus, a shunt is inserted, the child is well the next day, is discharged, and the child disappears. And we don't see the child anymore, and we don't know what happened. And I have seen this so many times, that the shunt is relieving symptoms, but the family has no resources just to do another surgery, or the family has no idea that it's critical to stay around. And I have seen this as well. The child has hydrocephalus, the shunt is inserted, the child is discharged. The family doesn't come back because the child is doing well. They come back 3 months later because the child is suddenly unwell again, but he has extensive metastatic disease. So it doesn't mean that the shunt should not be done, but the shunt is not a treatment. Most children with medulloblastoma, in fact, even with ventriculomegaly, do not need a shunt. What they need is they need surgery to relieve the pressure or the blockage of the fourth ventricle. And what about this initial surgery? Does the child need a biopsy, a total resection, a subtotal resection, a near total resection? In fact, the message here, the resection needs to be done by the surgeon who has experience in pediatric tumors. And this has been shown and again that the experience of the surgeon in pediatric tumor, and particularly in posterior fossa tumor, is critical to achieve a good resection with little morbidity. And there are data that show that the more you do, the better you are. So that's where the ownership of the patient is an inappropriate concept. If the surgeon doesn't know how to do it, he should share the patient with his colleagues or transfer the patient. And I know it's difficult in many places, but this is what is best for the child. And of course, the better the resection, the better the outcome, at least in non-metastatic patients. This slide shows that this was a study that was done in Ontario, and you may say, oh, it was a long time ago. It was nearly 40 years ago. And it showed that the cases that were treated outside a large hospital, which was sick kids, in other places had a lower survival than the patient treated at sick kids. And there were a lot of reaction to this paper, but this study has been repeated twice since, and including very recently, and has shown again the same results. So it's not something which is artificial, it's a reality. It's the more patients you treat, the better you are. This work is a work that we did at SickKid on more than 800 patients that we collected not from SickKids, but from around the world, just that to show that the full resection of a medulloblastoma is not critical. If the surgeon leaves a piece of tumor on the floor of the fourth ventricle, it will not change the outcome. So the aim is to achieve a good resection, but the resection that precipitates the child into major complication is something which is catastrophic and has no impact on survival. And the thing I wanted to mention here is the fact that surgery for posterior fossa, in particular for medulloblastoma, is associated with a specific complication called posterior fossa mutism. And in fact, there are data that show that this complication is relatively common. There are between 25 and 50% of the children with average risk medulloblastoma who develop some form of speech changes after surgery. And the symptoms can vary. They can be extensive, post-speech to no speech. And there are often other neurological manifestations: ataxia, irritability, abnormal eye movement, emotional liability, swallowing problem. So a wide range of symptoms and various degree of severity. And this can last for a few days to more than 1 year. I've seen patients who didn't speak for 1 year. But it will always leave the child with late and often devastating consequences. Don't think that it's going to recover, it's going to be fine. And there have been studies, and that's a study that was conducted by or led by St. Jude. And I know that Dr. Kadumi is going to speak soon, he's from St. Jude. But studies that have shown that when you compare a group of patients who had mutism after surgery and patients who had no mutism, here is a mutism and no mutism for medulloblastoma, you can see that even if they receive the same dose of radiation, you have difference in some tests, processing speed or attention, that show that there is a phenomenal difference between mutism and non-mutism patients. So a consequence, a direct consequence of the surgery, which is avoidable, and it seems that, for example, we have data that show that posterior fossa mutism is very low in large center, higher in small center. The incidence is higher when the surgeon has limited pediatric experience. And there are various factors that can be suggested, including the surgical technique, the age of the patient, the tumor size, the concomitant hydrocephalus. This is often how the scan shows on the flare. You have hyperintensity around the tumor bed. And I can tell you, if I see the scan after surgery, I can bet that the patient has very significant mutism in this context. So a complication that should be avoided at any price, if possible, because it can affect the child lifelong. And I'm not going to talk too much about surgery, but I want to mention that there will be a fantastic lecture in 2 weeks from now by Dr. Michael Dewan to the Pakistani team. And I invite you to attend. If you want any information, please contact Dr. Noreen Mushtaq because I know Michael and he's a great speaker. So what about radiotherapy? So it's the same. The more you do, the better you are. And remember, the technique of radiotherapy in medulloblastoma is unique. This is craniospinal radiation. It's a complex technique. And this is a technique where mistake can kill. And I want to mention 3 papers that have shown this. The technique of radiation matters. So this is a work that I have done with Christian Carré in the 80s and has shown that, you know, if you miss radiation in some place, for example, the cribriform plate, the child can have a recurrence. And this is something which will eventually lead to the death of the patient. But also there are some specific aspects that you need to be aware of. For example, the delay to initiate radiation has an influence on survival. The later, the bigger the interval between surgery and radiation, the worse the outcome. Ideally, the interval should be 4 weeks. If you go more than 4 weeks, you put the patient in trouble. But also the gaps during radiation. The time to complete radiation matters. Normally it's 42 days. If you go beyond 50 days, you will decrease the survival of the patient. So things that you need just to keep in mind. But also I want to warn radiation oncologists that there is a practice that has disappeared. The 3-year graduation ceremony where the child was receiving chemotherapy and should go and see the radiation oncologist, this is gone. The treatment of infant and young children with medulloblastoma is complex. Always ask the expert, and we are trying to treat as many experts, pediatric neuro-oncologists in Pakistan with Dr. Mushtaq over the next few years. So what about chemotherapy? You mean that I'm just shooting on the pianist and I'm not talking about chemotherapy? Chemotherapy requires also expertise, particularly with regard to side effects. We use different drugs of chemotherapy, but the one which is really dangerous is cisplatin. And the main issue with cisplatin is hearing loss. And up to 40, sometimes 50% of the children treated with chemotherapy experience some form of hearing loss. And we did some work in Toronto where we looked at the hearing loss according to the age and looked at the outcome in the long term. And we showed that patients who had a higher rate of hearing loss had a lower IQ in the long term. So it means that when you cause deafness on the top of the treatment that you give to the child, you will aggravate the neurocognitive outcome. And this was confirmed in a collaborative study led by people in St. Jude. There were just different people involved, including Don Mabot from our group, that showed that, you know, hearing loss has a cognitive impact in children with medulloblastoma. So a very important thing to do. And when you treat with cisplatin, you should be aware that it's critical to do a hearing test before treatment and during treatment to monitor hearing very carefully. I will finish and mention that sometimes, even if the treatment is over, you have to also to avoid mistakes. And that's the topic of relapses and pseudo-relapses. Some MRI changes can mimic relapse. And you should always raise a question as whether this is a relapse or not relapse. And if you have any doubt, just wait or biopsy. I take a few examples. This is a child who had no surgery of the primary side because she had diffuse metastatic disease. She got craniospinal radiation, a fantastic response. But unfortunately, 3 months later, while she was receiving chemotherapy, we could see that the mass in the posterior fossa was growing. I thought that this was over. So this patient had a terrible disease to start. And in fact, I learned from this because this patient is still alive, doing very well. It's 18 years after, and there was this sort of pseudo progression. And we didn't biopsy the tumor at that time, but it was really for me the first time I ever saw this. Another child just treated for an average risk medulloblastoma at the scan after radiation. While the child was receiving chemotherapy, we could see this lesion going here. And we said to the family, this is unfortunate, we don't know what to do, we should perhaps do surgery. They took the child and they left, and he didn't receive any more treatment. And he's a long-term survivor. And we think that this is, you know, a radiation side effect. And of course, it was not a relapse. And this one is even more really threatening because this was a scan at the end of treatment of a patient treated with a combination of surgery, radiation, and high-dose chemotherapy. And you can see that at the end of treatment, he had extensive enhancement in the posterior fossa and in the pons. But I knew at that time, and the child was clinically well, so I told the family, let's wait and see, and this is a scan 3 months later. This child is alive and well 12 years after the end of treatment, never received any further chemotherapy. So be very careful with any change and don't just jump and treat the patient if you see this. You need to learn from your experience or just discuss this with your colleagues. And so there were some publication on these changes, and in particular one from Dr. Fuladi a few years ago that was one of the first to report these changes, particularly after high-dose chemotherapy. So I will finish and tell you that a few years ago, we were just involved a number of people from high-income, low-income, and middle-income country in the writing of the SIOP adapted treatment recommendation for standard risk with medulloblastoma. We are going just to repeat this exercise because 5 years is a long time. And I hope that this updated version that is going to come soon will help you in your practice, wherever you practice, because we certainly have faced a number of new knowledge in our understanding of medulloblastoma and its treatment. So I will finish this and use a symbol that I like and I have shown in many conferences that, you know, when you treat a medulloblastoma patient, don't think you are alone, but also don't let the patient alone. So you have a big team of people and make sure that there is good communication between the different players, because this is, in my experience, the best way just to optimize the treatment of this patient. I thank you very much, and I'm happy to answer any question.
Thank you very much, Dr. Eric, for that wonderful presentation. We will be taking questions towards the end of this session. For now, we will be moving to our second presentation for this particular session, and the presenter is Dr. Ibrahim Kaddoumi. Dr. Kaddoumi is a pediatric hematologist oncologist at the St. Jude Children's Research Hospital, Memphis. He is currently an associate member of the St. Jude faculty and director of the Global Neuro-Oncology Program at St. Jude. He will be speaking to us on the many faces of precision medicine in low-grade gliomas. Dr. Kaddoumi, over to you.
Hi, everybody. Can you hear me? Good morning.
We can hear you, sir.
Yes, we can hear you.
Good. Let me share my screen. Just a second. I'm sorry, just a second. I tested earlier and it worked, so it should work. Okay, share. I tried it earlier and it worked, but I can't find my presentation. I should be able to share on my own, right?
Yes, you should go to the bottom.
Maybe I need to do the video, sorry. Okay, let's try this again. Did Eric stop sharing? Maybe that's the problem.
No, it is stopped.
I stopped sharing, Ibrahim. I stopped.
Okay.
Hi, Ibrahim.
Okay. Do you see my screen now?
Yes, we are coming on. There you
Do you
go.
see my screen?
Yes, we do.
Okay. Thank you for having me. It's always an honor and the pressure to speak after my mentor, Eric. So I hope I'll not disappoint you. I really appreciate having me in this meeting. So I started this new talk because people talk a lot about precision medicine and they fantasize about it. And sorry. Did I share my video? I mean, my camera, can you see me?
Yes, we can see you also, and we can see your screen as well.
Perfect. I'm sorry. We usually use WebEx, and I wanted to talk about it because people talk about it a lot and it gets a lot of publicity. And this will be the outline of my talk, and I'm going to give you a signal when I switch from one part to another. And this is a definition of precision medicine by a politician. And you can tell how politicians make things so simple and so nice and so easy. But in reality, it's not. And it's not only one thing, in my opinion. And why I like to talk about low-grade gliomas. They're more common than medulloblastoma. They're most diverse tumors in children, in CNS tumors. And they're very difficult to treat and can be a lifelong disease if we don't allow our neurosurgeon the window to resect them and cure them by surgery. And these are some facts about low-grade gliomas. This is a paper we did from SEER. They're really the most common tumors in children, CNS tumors, and there's the second most common cancers they're the most common CNS tumor in children. This is a study from SEER. 70% of children tumors were glioma, and as you see from these figures, and 70% of these gliomas were low-grade glioma. I know this is maybe higher than most studies, but in this study, we found that 50% of childhood CNS tumors are low-grade gliomas. So if any hospital starts a neuro-oncology service and focus on low-grade gliomas and medulloblastoma, they can say they're curing maybe most of childhood CNS tumors. This is an example of the why people who talked about precision medicine a lot. These are the common chemotherapy regimens in low-grade gliomas. I think everybody is familiar with them, but I want you to look at the CR, complete response rate. Complete response in children is very rare in low-grade gliomas to conventional chemotherapy. I personally never seen it, and I have doubts about these few cases reported. And we consider this the standard of care for 20 years. This is not a precision medicine. This is another problem with low-grade gliomas and why they were ignored. Overall survival in low-grade glioma is easy. 90% of children live more than 5 years. The problem is event-free survival, and this is German study. So if the tumor is not resectable, then you're stuck with a lifelong disease. This is a real case of mine. The patient has been treated for the low-grade glioma for 20 years, and each vertical line represents a real progression that the patient required the treatment for. And these treatments extended over 20 years. After 15 years, the child, we did not have many options, and the child continues to have these minor progressions. Do you see my arrows when I point an arrow? I'm sorry, I'm not sure if you'd see that. Do you? Okay. And these minor progressions took us a few years to treat because the family were not sure what to, which treatment to agree on. Finally, we had another surgery. He developed hemiparesis after the surgery, and he developed hidradenitis suppurativa, and now he's on Humira. So you can see how this benign disease can be a lifelong problem. This child has been on and off therapy for 20 years. Now going to targeted therapy, which is the poster child for precision medicine. And that's what everybody, they talk about precision medicine, especially politicians and the media. I'm not sure I agree with this because there are many phases for precision medicine, and targeted therapy is not the only one. In fact, I think there are many other phases of precision medicine that may be more important than targeted therapy. As an oncologist or a simple clinician, I simplify things. For me, cancer can happen if you activate a proto-oncogene or inactivate a tumor suppressor. And these are some of the tumor suppressors or oncogenes that are involved in low-grade gliomas, and I will talk about this in more details. You're all familiar with the tuberous sclerosis complex and NF1. This is one of our review papers about when I first started at St. Jude, and we talked about the pathway for activation of low-grade gliomas. I'll go back to this again, but there are mainly two pathways, PI3K, and that's mainly in the tuberous sclerosis complex, or the BRAF pathway, and that's in sporadic and NF1 patients. This is a structure of the BRAF gene, and you have the RAS binding domain and the kinase domain. And in one of the rare in pilocytic astrocytomas, rare aberrations in pilocytic astrocytomas is the point mutation in V600E. And this causes constitutive activation of the kinase domain or the BRAF. This means the gene is always active and does not shut down, and that causes a tumor. This is one of the nicest studies in childhood in CNS tumors. And in this study, after reviewing 1,300 CNS tumors, they found V600E to be common in two tumors, pleomorphic xanthochromic astrocytomas and ganglioglioma. As I said, it's rare in pilocytic astrocytomas. And this is important for diagnostic and therapeutic options. Going back to the BRAF structure, now we'll talk about the more common aberration in BRAF, or that's the fusion or duplication. Imagine the RAS binding domain gets truncated or cut, And according to how long is the truncation, you have some parts of the BRAF gene left, and usually it includes the kinase domain. Then imagine the kinase domain of the BRAF, this one, gets fused with another gene, and that's the most common, the KIAA1549. And then you have a new product that causes constitutive activation of BRAF. That's another way of activating the BRAF. These are other fusion products of the BRAF genes. Now we talked about pilocytic astrocytoma and ganglioglioma and pleomorphic xanthochromic astrocytomas. What about other rare tumors in children, especially the grade 2? You know, these are common in adults, and in children they are rare. In our study, we looked at 150 tumors. We did whole genome sequencing, and interestingly, 32 of these tumors were grade 2 tumors. And interestingly, we found that the FGFR in diffuse astrocytomas or grade 2 astrocytomas is the common finding. And that also, again, creates an opportunity for therapeutic option. And the aberration could be duplication or point mutation or fusion. So third of the diffuse astrocytomas have FGFR aberration. Interestingly, in this study, we found the only case of DNET we have was FGFR, showed FGFR aberration. So this made us start on our next project while we're finishing this. So we started collecting DNET cases in our database, and we looked at the biology of other rare tumors, low-grade tumors, and we wanted to look at if morphology and biology correlate. And interestingly, we found that the tumors that look alike also have similar biology. So the DNET or the oligotumors have FGFR, while angiocentric astrocytoma and diffuse astrocytomas have MEB aberration. And as expected, ganglioglioma have the V600E. Now, going back to the pathway I showed you earlier, you can see now where we could target low-grade gliomas. If you have V600E, you can use vemurafenib or dabrafenib. TAG580 can work in V600E and also in MEK inhibitors, as a MEK inhibitor. Selumetinib is a MEK inhibitor. Imatinib is a MEK inhibitor. And TAG580 works as a MEK inhibitor and also as anti-V600E. For the BI3K, especially if you have a tuberous sclerosis complex, you have the sirolimus and the everolimus work on these tumors. If you have FGFR aberration, you have FGFR inhibitors that includes davitinib and erdafitinib. Our experience with these two drugs, or especially erdafitinib, has been not good. Patients get a lot of toxicity. So this summarizes what people think of precision medicine when they talk about it. If you have NF1, then you use a MEK inhibitor. If you have a tuberous sclerosis, you use mTOR inhibitor. If you have BRAF fusion, you use MEK inhibitor. If you have EGFR, you use FGFR, you use erdafitinib. I want to share with you how exciting sometimes this can be. This is a real case of ours, the pre-dabrafenib imaging. 8 weeks after dabrafenib, you can see the tumor have an amazing response. The radiologist called me and asked me, how did the neurosurgeon resect such a tumor? It was not that, I told her it was a new drug we used. This was one of the first patients we used V600 inhibitors. And you can see after 16 weeks, more response. This patient has been on this drug for many years. Around the 3 year on therapy, he had 1 week of interruption. The family did not get the chemo, we mailed them, and the patient started having a clinical deterioration, and the MRI, as you see in the middle image, showed progression. So we resumed the drug, and the patient responded clinically within 2 days and radiologically with the MRI that was done 2 months after resuming the drug. So is targeted therapy the ultimate answer? I don't think so. There are a lot of problems with targeted therapy. It's for life now. We think it's going to be hard to stop. The cost, how many places around the world can pay $19,000 per month for life? Toxicity can be real and humbling. Cardiac toxicity, ocular toxicity, skeletal like FGFR inhibitors, and rash can be really disabling. One of my patients have about 70% of her body covered with rash. We have to stop the trametinib. This is my favorite kind of early diagnosis of precision medicine, which is early diagnosis, and I'm passionate about it, as you most of you know. I think it's as important, if not more important, than targeted therapy, and we should talk about it more. And I know Eric said that sometimes it doesn't affect survival, and this could be true sometimes, but I think many of these studies were not fair because they compared apples and oranges. I don't think in medulloblastoma you can compare anaplastic medulloblastoma and MEBIN. The real test will be if you compare MEBIN medulloblastoma that took 6 months to be diagnosed and MEBIN medulloblastoma that took 1 month to be diagnosed. And the same in low-grade gliomas. When we looked at grade 1 alone and grade 2, we found some differences. For the time restraints, I'm not going to explain in depth, but these are our studies. And even if you don't improve survival, functionality, as Eric hinted, which is important in treating children, can be significant cases when you have delayed diagnosis. These are some of the real cases I have over the last 17 years. The one on the right, a child took many years to be diagnosed, was seen by many specialists, had gastric workup, endocrinology, even genetic, and took that 3 years to be diagnosed. The one in the middle, 4 strabismus surgery before the MRI was done. And this one, the father diagnosed this child. The child have only unilateral nystagmus. Eric knows this girl. He saw her many times in Jordan. And that father insisted on an MRI for unilateral nystagmus. So I think you can tell who was the precision medicine. This is another 3 cases. In the right side, the patient took many years, progressive weakness, seen by different specialists. One of them is a neurologist. And look at the size of the tumor. The one on the left, 5 years took to be diagnosed. The one in the middle was lucky. The child was seen by a neurosurgeon who deals with St. Jude and thought of a brain tumor. I think many, very, very few physicians will do MRI for low back pain only. So I think you can tell which one is the precision medicine. Accurate diagnosis is really a very important phase of precision medicine. Without it, us as oncologists, we're flying blind. Pathologists are important part of the team. And this is one of my favorite studies ever done by Jonathan Finley. Please, everybody, keep him in your prayers and thoughts. He's fighting his cancer relapse and he's getting intensive chemo. He was very tired when I talked to him last week. But in this study, they found that 70 patients, about 30% of their patients with high-grade glioma were low-grade gliomas. And these patients, low-grade glioma patients, received radiation and chemo that they did not need. This is not a precision medicine. We think this doesn't happen anymore. This is a case we just had a few years ago. And this patient was in another prestigious hospital in the United States, was told to have high-grade glioma, had a port cast to start chemo, and the mother was told maybe even radiation if the chemo fails. Mother was a nurse and she asked for second opinion, and our pathologist, and with when we discussed him, thought this is a pilocytic astrocytoma, and the child has been only under observation after surgery and normal function. So this is a precision medicine, accurate diagnosis. Do no harm is another very important part of precision medicine, and sometimes the best thing we can do for the child is leave him alone or leave her alone. Especially in these cases I am showing in my slide. This is another real case. The child was diagnosed at the age of 9 months. We thought the left eye is blind because when you close the right eye, the child freaks out. So we recommended chemotherapy. The mother refused, and I almost took her to court. I talked to the social worker and the lawyer, and they asked me, if you don't give chemotherapy, would the child die? And they said, I said no. And they said, if you give chemotherapy, would you cure the tumor? I said, the complete response rate is low. They told me, you have no case, and leave the mother alone. And the mother was, I think, did better medicine than me. So this precision medicine was by the mom, not by us, the physicians. So precision medicine could be by not doing anything. My favorite part of precision medicine is MDC. I think without MDC, you cannot have a precision medicine. And the cases I mentioned to you could not have been achieved without precision medicine. And I know Eric showed this slide, and I saw this slide 17 years ago. I cannot get enough of it, and I always use it. Here I'm using it in a different way. I think this is the ultimate precision medicine, where all these people, all these disciplines focus on one single point, which is the patient, to provide the best outcome with the least toxicity. I think MDC is the lord of all precision medicine. So I'm going to share with you what I think precision medicine according to Kadumi, not Obama, and I think I'm more accurate. MDC, early diagnosis, accurate diagnosis, do no harm when you can, and targeted therapy. I'm not denying the importance of targeted therapy, but I really don't think it is, at this point, it's the most important in precision medicine. If you're not on a cure for kids, please join it. Many of these cases or points I discussed are part of my talks on the cure for kids, different talks, and I hope you can join them, or you can email me if you have any questions. I'm sorry I went over time. It took me a while to get used to the Zoom in the first minutes. I apologize for going 4 minutes over time. Thank you for allowing me to do that.
Thank you very much, Dr. Kumi. That was a very nice presentation. That's perfectly all right. The next presentation we have for this session is by the session chair herself, Dr. Nouri Mushtaq. Dr. Mushtaq is a consultant and associate professor of pediatric neuro-oncology at the Aga Khan University Hospital, Karachi. She is the only trained pediatric neuro-oncologist in Pakistan and has used her experience to establish pediatric neuro-oncology capacities in centers across the country, as well as start the first pediatric neuro-oncology fellowship program at the Aga Khan University Hospital this year. She will be talking to us about capacity building of pediatric neuro-oncology services across Pakistan. Dr. Mushtaq, over to you.
Thank you so much, Faisal, for your kind words. And thank you so much, Dr. Athar and Dr. Shazad, for inviting me to give this talk. And this talk is something which is close to my heart. Can you see my slide?
It's not totally on, but I think it's probably coming on. Okay, we can see it now, but that's the last slide.
So the topic of my today's presentation, as Dr. Faisal said, is capacity building of pediatric neuro-oncology in Pakistan. I have no disclosure, no conflict of interest. So when we see about the high income countries, so we see most of the research and the drugs and all those things, and the funding is basically goes to the accident and the cancer, and that will make the quality of life of these patients better, and then the majority of the advancement of the cancer is coming up. But if you see in our part of the world, in the low-income countries, so most of the funding and all those funds and resources will go towards malnutrition, to treat malaria, respiratory infections, infant mortality, mother mortality, and HIV, and a very, very small percentage goes to the cancer research. As essentially, there has been a very minimal amount of research at this point in time. So this will grossly impact the survival rate of cancers in the low middle income countries. So if you see the survival rate of children in high income countries more than 70%, but if you see this graph in the low middle income countries, even less than 50%. And why is that so? Do we think that if we have more molecular biology, sequencing, targeted therapy, high-tech medicine, we will improve? It's not actually that. What we need is actually the multidisciplinary team. If you see the amount and the percentage of the children diagnosed with cancers in high-income countries, almost 20% around the world, and the outcome is more than 75%. But in low middle income countries, the percentage is about 80% and the outcome is not less than 25%. The story even worse in brain tumors. When we have only 10,000 new cases diagnosed per year in the high income countries and the outcome is 70%. But if you see in the low income country, around 40,000 new cases diagnosed and the outcome is not more than 10%. If you talk about Pakistan, so we don't even have an outcome of 5%. So even at this point in time, 4 out of 5 children still die with brain tumors. So when I had my fellowship, most people asked me why pediatric neuro-oncology. So I said, why not? So we all know that it is the leading cause of cancer-related morbidity and mortality in pediatric age group. It's not the uncommon, but it's actually the most common solid malignancy and the second most common childhood cancer. Even at AKU, we have more brain tumors per year, around 60 to 80 patients per year, than leukemias and lymphoma. And the number of leukemia and lymphoma is not more than 40 to 50 patients per year at AKU. But why people are not opting to do it? Because we all know that it has a devastating diagnosis. The results of treatment are not satisfactory. And it's not only that the disease is bad, but the long-term complication and complexities related to the treatment itself, it's a lot. And the most important component is the multidisciplinary team management. So you are not treating your patient alone, but you need a whole bunch of colleagues who will help you out to improve the quality of life of this disease. But still, there is no consensus of treatment in most of the centers, and palliative care in pediatrics is still non-existing in Pakistan and in many of the low-middle income countries. So this is the same graph Dr. Eric and Dr. Kudumi has shown you, but this is for the leukemia lymphoma. You see this small flower, so it has a very like 5 patterns in which you only need oncologists, a pediatric oncologist, a labs, pharmacy, and nurses to run a pediatric leukemia program. But what are the critical partners in the neuro-oncology? So we need good neurosurgeons who has experience and awareness of pediatric brain tumors, neuroradiologists who knows and who have the equipment and the quality of the imaging is good enough, our pathologists who have experience equipment in doing neuropathology, our radiation oncologists who are always available and ready to share their experiences, and last but not the least, our pharmacists and nurses. So, so you have already seen this diagram. We all love this diagram, from Eric to Ibrahim and now myself. So in the neuro-oncology, it's very, very complex. So you should not be alone. So you have, for pediatric neuro You should have a neuro-oncologist, neurosurgeon, radiation oncologist, neuroradiologist, psychiatrist, nurses, um, uh, and a whole bunch of a rehab team to improve the outcomes. And if there is anybody who is not present, so the outcome will really bad if you don't have the whole players in your team. So this is what we do have, or what we can do. What are the basic and main challenges we have? So the main challenge we have in Pakistan is the resource limitations, which impact across the border, including imaging, pathology, and rehab. So our multidisciplinary care, we all know that is poor. It's not only that people don't want to do it, but the problem is we have essentially a very low rate of referrals, even before surgery or after surgery, because people have less amount of education, and the program is not there, and the poor lines of communication throughout. And we have less amount of rehab, educational, psychological support, and constraint make it critical to consider late effects when planning treatment. So there are many childhood cancer initiatives which has been done in low-income countries. And the key here is to train people, including the faculty members, pediatric oncologists, neurosurgeons, radiation oncologists, fellow and residents. The other key is there should be international collaboration, as we have done with the hospital sector in Toronto, with other world-renowned centers. And the way forward is citing age-specific physicians, surgeons, and radiation oncologists, which will later on lead the neuro-oncology program or any other program to make it better, and site-specific tumor boards. I must say and congratulate all of my colleagues that site-specific tumor boards are not only we are doing in Pakistan, but at APU, but we are doing it in the Indus, at Shakathanam, and many other centers. So it's still there. So how can we start? So how can we start in neuro-oncology? So this is a twinning initiative. So you have various twinning initiatives for the leukemia lymphoma programs, but you won't find much for the neuro-oncology program twinning initiative. So this one is the first one, and very well run by started by Dr. Ibrahim Kudumi and my mentor, Dr. Eric Buffet. So they have initially started back in 2003 with the supplementation of a successful pediatric neuron telemedicine-based training program. Initially started with emails. So at that time, around in a span of 29 months, they had exchanged 356 emails to improve the quality of life of the patients Dr. Ibrahim Kudumi has at the King Hussein Cancer Center, Jordan, which then followed by their first pediatric neuro-oncology telemedicine tumor boards at King Hussein Cancer Center. And what they found, it has an extremely impactful change that they see in the outcome of their patients. So can we do something in Pakistan? So Pakistan, we have around 204 million people population, and we have around 31.6% children who are less than 14 years of age. So, but the problem we have here is there is no subspecialization. There is less amount of team approach, as there is no or minimal education related to the pediatric neuro-oncology. So there are late referrals starting from the primary physicians, pediatricians, pediatric neurologists, neurosurgeons. So there is significant late diagnosis at late referrals. As Dr. Eric said, BP shunt first, and it basically don't depend on the surgeon expertise. Actually, it's your center in which you are doing. So if your center is not equipped, you have to put a VP shunt first. But then, as Dr. Eric said, if you have a VP shunt first, most of the time, children will never return. And radiation for most of the tumor, because we don't know, and the MDT is actually not that strong for neuro-oncology. And there is long interval between surgery, radiation, chemotherapy, and lack of trust, by the patients, families, and parents. So they run from one doctor to another, and this will delay their children diagnosis. So when I come across the data in Pakistan, so I only have few papers, around 8 to 10 papers from pediatric neuro-oncology or brain tumors in Pakistan, and unfortunately, these papers are 80% of these papers are from pathology teams, and only one paper is from a center in Pindi, who tells us that they have only 5 brain tumors in 10 years. And the outcome of those patients were extremely poor. So there's not much data in Pakistan. So we usually work like this. So we have a patient in the neurosurgery, and then it will take quite a lot of time for pathology to give the results, and then a lot of time in the radiotherapy, and then there is no, many patients even don't go to the neuro-oncology on the pediatric oncology teams. So with this limited experience, there is still lots of things can be done. So what we need a minimum of infrastructure. And fortunately, we do have a minimum of infrastructure in many of the centers in Pakistan. Like majority of the centers have imaging, neurosurgery, pathology, radiation, pediatric oncology or adult oncology and rehab. So we can build on this. And then ideally, they should have a network that could support tuning initiative. And then when you start all this training initiatives, you can develop protocols which can be feasible for a low middle income country like Pakistan. So this was the data I had from 2004 to 2014 before I came back from my fellowship from SickKids. So from 2004 to 2014, we have registered around 175 children between the ages of 1 to 16 years. And most of these children has astrocytomas. And in the other table, you can really appreciate, this is the table from the Indus Hospital, previously known as Children's Hospital, and they only had 7 patients in 13 years of brain tumors. So there is not much data we have for the pediatric brain tumor before 2014. So we have started this training program with the Hospital 6 Children Toronto under the leadership of my mentor, Dr. Eric. So we are not the only center we have started it, but actually we are the leading, and our partners are in this hospital, NICH, JPMC, Atomic Energy Centers. So the team includes pediatric oncologists, neurosurgeons, pathologists, radiologists, radiation oncologists, and nurses. So initially we have started this as Dr. Kudumi has developed, like with the emails communication, but it's subsequently followed by monthly video linked based pediatric tumor board, and still the first one, which is an international pediatric tumor board in Pakistan, and we have been running this for the last 6 years. It's usually, so we usually have it every 3rd or 4th Wednesday of the month, and the team from the SickKids is led by Dr. Eric, and also other members including Dr. Uwe Tabori, Dr. Vijay Baswami, Dr. Uti Bartels, Dr. Cynthia Hawkins, the neuropathologist, and many fellows and neurosurgeons. So what this team helps us is that we do have regular meetings. It's not only that we share the knowledge, but we also share the different protocols. And with this, we also send our samples of histopathology, not only from AKU, but from Indus and from NICH. So we sent around 186 histology samples to SickKids for second opinion. It not only tells us about the basic pathology, the basic morphology, but also they help us a lot in the molecular subgrouping of the medulloblastoma and many newly molecular markers or the NGS to diagnose our children's better. So this is the picture of our regular meetings of the tumor board. This is our team from AKUH. So this was the image when Dr. Eric visited in 2017 at AKU, and we had a great time. So what this activity helps us is our referral system increased, and at this point in time, we do have 65 to 75 or at times 80 and 86 new patients of brain tumors per year. We have more referrals across Pakistan. We have developed multidisciplinary team of pediatric neuro-oncology. We have the Community Tumor Board, which actually improve quality of life of children with brain tumors. It also helps Indus and NICH to develop their own standard protocols for medulloblastoma and low-grade glioma, and even Indus has a lot more referrals at this point in time after they have joined us in this activity. So these are some of the papers which we have with the international collaboration. And it's not only myself, but Dr. Bilal Masar Qureshi, who is part of the radiation oncology at AKUH. We are also part of these three papers. One is the PSYOP guidelines for the low-grade glioma. The other one is the radiation guidelines for the low-middle-income country. And the third one, just published, is the PSYOP guidelines for craniopharyngioma. So then this whole activity will lead us to have this grant, which we had back in 2019. And this is the Sanofi for Aventis grant. And through this grant, we basically, so our plan is to basically to develop capacity building across Pakistan of pediatric neuro-oncology. So our neuro-oncology members includes myself and Dr. Bahar Javed from the neurosurgery, Dr. Khurram Minhas from pathology, who's already a part of this pediatric neuro-oncology team since 2014, Dr. Fatma Mubarak, who's in neuroradiology, Dr. Salman, who's an endocrinologist and a geneticist, pediatrics, Dr. Rehisham, who is a pediatric palliative care physician, Dr. Bilal, who is the radiation oncologist, and Ms. Anam, who is our neuro-nurse navigator. So the participants, so I talked with all these centers and their participants, and all of these centers, which including 3 centers from Karachi, including Indus, NICH Hospital, JPMC, Indus Hospital, Atomic Energy Center, 7 centers from Punjab, Shaukat Khanam, Children's Hospital Lahore, Children's Hospital Multan, Lahore General Hospital, Pins, Mayo, and Liaquat University, Jamshoro from Sindh, CMH Pindi, PIMS, and Northwest Hospital. So all these centers, coordinators, is highly enthusiastic, and they were ready to be part of this activity. And since last year, we have had excellent collaboration with all the team members of these 10 hospitals. And I'm really impressed with the amount of work and the amount of enthusiasm their residents and their fellows are having to improve the quality of life of children with brain tumors. And they are all on board and helping children to have a better outcome in Pakistan. So this is basically, so we have basically divided our activity in 3 years. In the first year, we basically, our first action is to develop tumor boards and to have a pediatric neuro-oncology symposium and to start a neuro-oncology fellowship. So these are the tumor boards which we have developed since 2019 August. So since then, we have around 33 tumor boards. We have established 3 tumor boards. The first one is the JPMC NICH tumor board, in which the JPMC team led by Dr. Uzma, the NICH team led by Dr. Uzma, the JPMC team led by Dr. Nazraman, and the AMC team is led by Dr. Hina Ashmi and Dr. Mohammad Ali Maiman, while the LUMS team is basically led by Dr. Raja Riaz, and they're enthusiastic and very hardworking residents. And the Punjab tumor board led by many centers, including Dr. Alia and Dr. Shazia from Children's Hospital Lahore, Dr. Najma and Dr. Saad from Shaukat Khanam, and many others, centers and colleagues. So we have had these 3 tumor boards per month, and since August, we have around 33 tumor boards and around 127 cases have been discussed up till now. So these are the workshops which we have planned, and this was the first workshop we have had last year in Lahore at the Children's Hospital, and in which there were many participants very highly enthusiastically participated by many participants from Lahore General Hospital, PIMS Hospital, Shaukat Khanam, Children's Hospital Lahore, and Multan. And we have had around 69 participants in this workshop. This workshop was then followed by another workshop at LUMS Hospital in November 2019, and we have around 43 participants in this workshop. The third one, before COVID, is the workshop we have had at the JPMC AMC Center, and we have around 48 participants in the workshop. So people are coming in, people are doing more, and everybody from these centers wanted to improve the quality of life and develop their own capacity of pediatric neuro-oncology in their own centers. Not only the neurosurgeon, but the oncologists, pathologists, radiologists, and radiation oncologists. So, so it's not only that we have to have our only workshops and tumor boards, but we have to keep it forward, make it forward. So for this education and training, We have just started in July 2020 our first pediatric neuro-oncology fellowship approved by UGME. And Dr. Afia, RFS Basic, is our first pediatric neuro-oncology fellow. Dr. Afia is a consultant at Lahore General Hospital, and she will be with us for the whole year to complete her fellowship. Not only the fellowship, we also have national and international observerships as part of our grant. Um, uh, uh, it will be started like once the COVID thing settles. So we will send around 9 participants to Sickles Hospital for observerships for neuro-oncology, for neurosurgery, radiation oncology, and radiology and pathology. And we will basically invite around 9 participants from all these centers to come to AKUET for the national observership at AKU with different departments, including neurosurgery, radiation oncology, and pathology. So the other thing which we do, which we have started back in April this year, is the pediatric neuro-oncology lecture series by the international faculty. And up till now, we have had 16 lectures. And in those lectures, we have a very, very good number of participants. And we have had around 1,279 participants in those 16 lectures. So last but not the least, we are planning to have our first National Pediatric Neuro-Oncology Symposium later this year in November 27 and 28. Please save your dates for this. It will be physical or virtual if things settles. So in the end, I will summarize and close this. So cancer and brain tumors, the leading cause of disease-related deaths in high-income country, and will be someday in low-income countries. The future of neuro-oncology depends on international collaboration, but we should have patients for clinical trials, helping centers to develop basic pediatric neuro-oncology care, epidemiological studies for prevention should be the way forward. And later on, we may have to think about innovative treatment strategies. We have to have tissue samples for biological studies to have better outcome for our patients. Thank you so much, and thanks for your patience, and I'm happy to take questions in the end.
Thank you very much, Dr. Mushtaq. We will now be moving on to our fourth presentation for today. The presenter is Dr. Mohammad Nauman Mughal. Dr. Mughal is a PhD and an assistant professor in the Department of Surgery at the Aga Khan University, Karachi. During his PhD at the Karolinska Institute, Stockholm, he studied the chromatin remodeling capacity of genome maintenance of the gamma herpes viruses. He has served as assistant professor in the Department of Pathology at the Dow University of Health Sciences, where he led research at the Virology and Vaccinology Research Lab. He will be talking to us regarding the introduction to the molecular basis of epigenetics. Dr. Mughal, you may begin. Dr. Mughal, I believe you're muted. You need to unmute yourself.
Can you hear me now?
Yes, sir.
Okay. Good morning, everyone, and thank you, Faisal, and thank you, Dr. Athar, for the opportunity. In today's presentation, I'm going to discuss briefly about the different mechanisms of epigenetics, which are responsible for maintaining the dynamic nature of genome. So, before I start about the epigenetics or epigenome, I'm going to tell you how a genome is organized within the nucleus. So we have double-stranded DNA, and there is a huge amount of DNA which is present in our eukaryotic cell. And in normal condition, this DNA cannot be accommodated in a nucleus. So in order to accommodate the huge amount of double-stranded DNA, the DNA required packaging, and there is a very organized way of packaging this DNA into nucleosome, and then nucleosome further get assembled, and in this way, this whole genome can be packaged within tiny nucleus. This serves two purposes. First, it occupies a little space, and second, the packaging packaging of DNA is very
Dr.
important.
Mohan, if you can speak louder, because we can't hear you.
Oh, 1 second. I hope you can hear me now.
Not clear.
Can you hear me now?
Yes.
Yes, it's better now.
That is better. Thank you.
Okay. So this packaging serves two purposes. One, it accommodates huge amount of DNA into a tiny nucleus, and the second, this mechanism is very important for preventing the DNA damage, which can occur to double-stranded fragile chains. But at the same time, it makes very difficult for different cellular machinery like transcriptional machinery and replication machinery to access chromatin. So what we need a mechanism that can create a dynamic nature of genome so that when we require chromatin, it can be open, and when the function is done, it can be closed. So you can see in this figure that we need a cycle where chromatin compaction and chromatin decompaction can be done. In our cells, this mechanism is the function of epigenome. So epigenome is responsible for the dynamic nature of a genome. There are three components of epigenome which plays the most important role. One is the proteins which are associated with DNA, or we call them chromatin. Second, the methylation signature on different cytosines. And third, which are also the research interests of Dr. Atal and mine also, is non-coding RNA, especially microRNA and LNC-RNA. These factors play a very important role in maintaining the dynamic nature of genome. These three factors work together to achieve two goals. One, the chromatin compaction and decompaction when required. And second, they mark DNA so that different DNA binding proteins can come and bind to the marked DNA and perform their function. And the main function or main goal of all the decompaction and the marking is to achieve one thing, and that is gene expression. The gene expression of different genes in different conditions, in different tissues specifically, and this is the main goal which is achieved through the component that is non-coding RNA, DNA methylation, and histone modification. So first I'm going to discuss about the histone modification, how it works. So we have, as I said, that for DNA packaging, we need assembly of DNA in the form of nucleosome. What are nucleosomes? In nucleosome, you have 4 different proteins dimer. Those are H2A, H2B, H3, and H4. They work together, interact with each other, and form a big ball of which is called octamer. And DNA and this ball or these histones are basic in nature. That's why they can bind to the negatively charged DNA. And this DNA and the octamer form a nucleosome. Within 2 nucleosomes, you have another histone that is called linker histone. It comes and binds to the linker DNA. It makes sure that DNA doesn't slip. By doing that, we again create a paradox that by the formation of nucleosome, the DNA is now trapped. So again, we need a system so that we can assemble the nucleosome so that replication and transcription can be done. In order to achieve that, what is happening that if you look at this nucleosome, the most part of the histone protein is within the core of nucleosome. But you see these tails coming out. These tails are the tails of histone proteins. And they are the site of different modifications, different chemical moieties which can be added to these tails. By adding different moieties to these tails, we can change the conformation of nucleosome. For example, as I already discussed, the histones are basic proteins. They are positively charged. So if we need to disassemble this nucleosome, we need to make these histone negative. So what is happening that the acetyl transferase enzyme is coming and adding an acetyl group to the histone tails. By adding acetyl group, it creates a negative charge on the histone protein. And because the DNA is negative, histones are negative, So negative, negative repel each other and the nucleosome disassemble. But once the function is done, what is happening? Another enzyme is coming and removing the acetyl group. By removing the acetyl group, the histones are again becoming the basic, and then they can go back and bind to the DNA and assemble a nucleosome. By adding different moieties to the histone tail, you can change the charge of the histones and assemble and disassemble nucleosomes. There are a number of moieties which can be added. The most important ones are methylation, acetylation, phosphorylation, and ubiquitination. These molecules can be added to the tail of all the 5 histones, and by adding these different moieties, you can change the charge, and then you can open and close chromatin for different functions. But we have to remember that these modifications are reversible. So for these, we have 3 different groups of protein which plays their role in introducing histone moieties and then removing them. One group is called writer. These are the enzymes which are responsible for adding different moieties, while eraser are the enzymes which work against the writers and they remove any mark. For example, if you want to add an acetyl group, there are acetyl transferase, but when you want to remove, then there are deacetyl enzymes. But there is a third group of protein which are called readers. These readers are the protein which can recognize modified histone, then further recruit different chromatin remodeling complexes which can perform functions like DNA repair, DNA transcription, and DNA replication. So writer introduce the modification, eraser remove the modification, and readers recognize the modification and can further recruit different machinery of different functions. The main modifications or the most critical modification, as I said, are acetylation, methylation, ubiquitination, phosphorylation. These are the main modifications. For acetylation, the main amino acid which get attached to the acetyl group is lysine, and the enzymes which introduce acetyl group are called generally HAT, histone acetyl transferases, while the enzymes which are responsible for removing acetylation is HDAC. Similarly, methylation can be done on lysines of the tail and also the arginine. These 2 residues are substrate for methyl introducing groups, and the enzymes are HMT and HDM. In the similar way, ubiquitination and deubiquitination is also prefer lysines on the tails, while phosphorylase, the phosphate group is added to the serine and threonine by the enzymes kinase and phosphatase. So kinase add phosphate group, while phosphatase enzyme is responsible for removing the phosphate group. What are the main functions of acetylation? The acetylation, as I said, bring a negative charge. So by bringing negative charge on or adding negative charge to the histone, it creates a repulsion between histones and DNA. And due to that repulsion, the DNA becomes decompact. And decompaction is very important when different transcriptional factors want to bind to DNA and then proceed with the transcription. The second function, which is very important for acetylation, is the binding of different chromatin remodeling complex to the DNA. And it is also the function of acetylation. The acetylated histone can recruit chromatin remodeling complex, and these chromatin remodeling complex plays very, very important role for transcription, DNA repair. Acetylation and methylation work against each other. Acetylation means the opening of the DNA, while the methylation means the compaction of the DNA. So in our cell, we are always having this function that acetylation of DNA is promoting transcription, while once the transcription is done, the methylation is closing DNA again. As I mentioned already, that lysines are the residues which preferably get methylated. Methylation can be monomethylation, dimethylation, and trimethylation, and depending on the residue where these methyl groups are attached, and also the tail of different histones, this methylation can be repressive, and at some time it can promote transcription. The other function of lysine methylation is heterochromatin formation, X chromosome inactivation. Similarly, we have phosphorylation, and phosphorylation can be done on serine and threonine amino acid. The enzymes responsible are called kinase and phosphatase. Here they have given the example of histone 3 phosphorylation at serine 1, serine 10. And this modification is done by enzyme Aurora B during mitosis. And once the mitosis is complete, this modification is removed by phosphatase PP1. The other function where phosphorylation of histones play very important role is transcription, DNA break, repair, and apoptosis. So these are different. There are different sites on histones protein where addition of phosphate group will going to result in different functioning of different genes. The second component which contribute in epigenetics is non-coding RNA. Non-coding RNA, especially long non-coding RNA and microRNA, play with the epigenetic or epigenome in number of ways. But here I'm going to give you an example where long non-coding RNA can change the chromatin methylation status or acetylation status. If you look at this figure, you can see the long non-coding RNA here is hot air, which is a very critical long non-coding RNA in different glioma and also in GBM. So what this hot air is doing, it is interacting with HBX1 protein and MYC protein on one side and recruiting LSD1 on the other side. So by recruiting this complex at a promoter of c-MYC target, it can promote demethylation. This demethylation results in the activation of c-MYC target. So by demethylating the target promoter, by removing the methylation signature, it can promote the different targets of c-MYC gene. On contrary, a promoter of WIF1, hot air is recruiting PRC2. By recruiting PRC2, it is promoting the methylation of WIF1 promoter. And by inhibiting WIF1 promoter, it is actually activating Wnt beta-catenin pathway, because WIF1 is an inhibitor of Wnt beta-catenin pathway. By inhibiting WIF1, the Wnt beta-catenin pathway becomes active. So by interacting with the chromatin remodeling complex and recruiting at the promoter, the long non-coding RNA plays very important role in changing the methylation signature of different promoters. One of the most studied aspect of epigenetics is DNA methylation, and we, Dr. Adar and I, are also interested in this process, especially in the context of microRNA in GBM and in glioma. So what is DNA methylation? So DNA methylation is the addition of methyl group to the cytosine, 5 carbon of cytosine, and how it works. So so there are two stages with which the methylation group is introduced. During after gamete formation and during embryogenesis, the DNA passes through a phase where there is no methylation signature on DNA. So you can see this chain, there is no methylation attached to it. And this is the phase after gamete formation and during embryogenesis. Once that phase is passed, then methylation group needed to be introduced. So when there is no methylation signature, the type of methylation which is required is called de novo methylation, because we are starting from the scratch. Then enzymes DNMT3A, DNMT3B, and DNMT3L comes together, and then they start to introduce methyl group to different cytosines, especially within the promoter. By adding methyl group to one chain, they created a DNA which is called hemimethylated DNA. Now comes a second group of enzymes, which is responsible for the maintenance of methylation. So it means DNMT1 doesn't introduce any methyl group at a place where it wants. Rather, it has to just copy the signature which is placed during the de novo methylation. So DNMT start to introduce methyl group on the C's opposite to the already methylated group. In this way, now both chains are methylated at CPG islands. These two, de novo methylation and maintenance methylation, plays the most important role in regulation of most of the genes in our body. The enzyme, as I already said, the enzyme responsible for the de novo are DNMT3A, 3B, and 3L, while the maintenance is responsibility of DNMT1. Like histone modification, DNA methylation is also a reversible process. And the enzyme in mammals and in humans, which are responsible for removing DNA methylation, are TET proteins. There are 3 TET proteins, TET1, TET2, TET3, and another PDG protein. And in our group, we will be studying the effect of TET1, TET2, TET3 on the methylation signature of different microRNA, which are overexpressed in glioma and GBM. What is the main role methylation plays in mammals? Most importantly, gene expression, then maintaining the chromosomal stability, cell differentiation, imprinting, X chromosome inactivation, carcinogenesis, and aging. Because of these multiple roles, DNA methylation is the most studied aspect of epigenetics, and it is in cancers, in different diseases, it has been seen the genes get aberrantly methylated, and this function plays very important role in causing cancer, in different disease, different genetic disorders. So what is happening? So we have totipotent cell which convert into pluripotent, then multipotent and unipotent. And you can see that signature, the methylation signature. So totipotent had less methylation. So more genes are available to become any cell of the body. But with the passage of time, the totipotent, when converted to pluripotent and multipotent, the methylation signature is increasing until cell is completely differentiated and have the maximum methylation signature. So if any aberration or any problem occurs from multipotent to unipotent, you can have a cancer cell, or at any stage in a problem with a methylation signature. So basically, what is happening that you have a pluripotent. These highlighted yellow highlighted points are the sites where methylation can occur. So in pluripotent, these sites are unmethylated, and after the cell passes from pluripotent to unipotent, you can see that these sites get methylated. In our group, what we are doing, we are basically understanding the methylation signature of different microRNAs which get aberrantly expressed in brain tumors and especially gliomas. So what we are doing, currently we are working with microRNA 21, and what we are doing, we are first MIR21 expression is already established that it is highly expressed in GBM. So we also quantifying the expression of MIR21 in our tumor samples. Then we will be identifying the promoter methylation signature of MIR21 and identifying the differences between the control brain sample versus the cancer sample. So what are the positions which are very critical for the aberrant expression of MIR21 in GBM? Then using those positions, we will try to pull down different chromatin remodeling complex, different proteins of methylation and demethylation, which may be recruiting in case of GBM, and by inhibiting the recruitment of those proteins, which we can reverse or restore the normal MIR21 function. And by restoring the normal MIR21 function, we can actually move cell towards the apoptosis, because MIR21 plays very important role in uncontrolled growth of GBM cells. So why is very important? One of the reasons it's very important to study further epigenetic modification is these are reversible. So if we can identify specific epigenetic signature of different cancers and different disease, then we can also reverse them. And by reversing them, it can be very beneficial for the patient. The second, we need to do large-scale epigenetic profiling of different people belonging to different avenue of the life, having different social factors, social and psychological attributes, so that we can identify different signatures and then start work on creating a profile which can be used for identifying different disease and different diseases. It's all from my side. Thank you very much. And if you have any question, please do ask.
Thank you very much, Dr. Mughal, for that all-encompassing introduction to epigenetics. We will now move to the fifth and second last presentation for this session, delivered by Dr. Ho-Shin Guak. Dr. Guak is a consultant neurosurgeon at the National Cancer Center, Goyang, Korea. He attained an MS and PhD in neurosurgery, as well as completed his fellowship in brain tumor and gamma knife radiosurgery from the Seoul National University Hospital, Korea. As a clinical researcher, he takes keen interest in radiation biology and cellular biology. He will be presenting to us today on the recent challenges for diagnosis and treatment for leptomeningeal metastasis.
Surgeon and currently president of Korean Society for Neuro-Oncology. I congratulate your inauguration meeting of Pakistan Society of Neuro-Oncology. Today's my topic is a recent challenge for diagnosis and treatment for leptomeningeal metastasis. Incidence of this disease is recently increasing with the long-term survival of cancer. Hence, up to 10% of all cancer patients could experience this disease. Natural history of the leptomeningeal metastasis is dismal. It quickly devastating patient performance, and in spite of intra-CSF chemotherapy, the survival benefit is marginal, with the consideration of neurotoxicity. Proportional incidence is highest in melanoma, but relatively frequent cancer of breast and non-small cell lung cancer has a high incidence, so we can meet these patients frequently. And another risk factor is concomitant parenchymal brain metastasis and some histologic subtype. Let's see the definition of this disease. This disease is a dissemination of cancer cell to the arachnoid and pia mater through CSF flow. Diagnosis is made by floating cancer cell in the CSF, but actual disease occurred in subarachnoid and pia space. So, due to the paucity of the floating cancer cell, CSF cytology frequently yielding a false negative result. So we need to repeat up to 3 times for negative judgment. Even in combination with MRI diagnosis, the diagnostic yield is around 60%. So some pathologists try to discriminate the cancer cell from WBC using the special immunohistochemistry such as cytokeratin for epithelial tumors, but preparing 2 slides per small amount of CSF sample is not an easy job. Recently, Swedish group and the New York Memorial Sloan Kettering Cancer Center tried to catch these cells using flow cytometry, but this flow cytometry is somewhat specialized equipment, and tagging the circulating tumor cells with the fluorescence labeled antibody against the EpCAM, epithelial cell adhesion molecule. It is quite interesting, but as you can see here, catch the hundreds of thousands of cancer cells in CSF requires a quite large amount of CSF volume. 10 millimeter is, in my experience, not enough. For this scale, we need hundreds of millimeters of CSF, so it is yet hard to be generalized. So I paid my attention to catch the metabolomic profile. Metabolomics can reflect the cancer cell behavior. With recently developed sophisticated mass spectrometry equipment, we can catch the many low mass ion in detail, and data mining procedure with the help of bioinformatics can discriminate the cancer easily. In my experience, the low mass ions in the patient's stool can diagnose colon cancer with this 95% sensitivity and specificity, which is superior to the conventional occult blood testing. So we are surprised that our clear CSF has so many discriminating low mass ion up to tens of hundreds. And among these, more than 400 low mass ion has a discriminant power among the patient group. Each low mass ion can be identified as a parent molecule in human metabolome database, as you can see here. And using this algorithm, we can select some group of low mass ion that can discriminate the patient group from the controls. We selected 21 low mass ion groups that we call the LOMA21. This LOMA21 can discriminate leptomeningeal metastasis from high-risk group of brain metastasis and brain tumors with this perfect predictability. And identify the low mass ion is, for example, phosphocholine, which is an ingredient of membranous membrane of the central nervous system. So it looks very hopeful, but this kind of profiling need external validation in another set of large number. So we are performing prospective external validation with 600 patients. We using the CSF cytology sample as the pathologist only use the precipitate of this CSF. For slide smear, we can detect the low mass ion in their supernatant. This result will become the early next year. After the diagnosis, let's talk about the treatment for this leptomeningeal metastasis. At large, radiation, CSF chemotherapy, and systemic chemotherapy is available, but all these treatment modalities should cover whole neurosix as the disease spread whole neurosix. How about whole brain LT? Even whole brain LT can hardly prolong the patient overall survival. But in case of a localized mass region, radiation therapy is very effective for this disease. How about systemic chemotherapy? Systemically administered drug can hardly achieve the effective concentration because the CSF penetration of this drug is less than 5% of serum concentration. But in case of a small molecule with a target inhibitor, for example, receptor tyrosine kinase inhibitor in non-small cell lung cancer, it showed a quite superior result when we use them with CSF chemotherapy. Some literature says that the penetration rate of this small molecular weight inhibitor is poor, but they can act in the CSF with at a low molar concentration of nanomolar level. So how about intra-CSF chemotherapy? 30 years ago, National Cancer Institute of the United States of America performed this pharmacokinetic study, and 1/50 of the methotrexate can achieve the effective concentration, both one-time bolus injection more than 48 hours. So it looks promising, but we have a very limited number of available drugs for intra-CSF chemotherapy. So up to now, only 6 drugs underwent more than phase 1 trial for intra-CSF chemotherapy. And one of the promising drugs is, for example, herceptin for HER2-positive metastatic breast cancer. According to the one systemic review, clinical improvement and CSF cytology response rate up to 2/3 of administered patients. Let me show my experience. This is a 45-year-old metastatic breast cancer, HER2 positive. After removing the brain metastasis, even we apply the tumor bed radiation therapy, there's a CSF contact recurrence in tumor bed. So I apply the intracerebral herceptin 2 times, and I can see the response. But we still have problems in intra-CSF chemotherapy. As you can see here, lumbar puncture is very bothersome procedure, very painful to patient, and worry about the unsafe needle positioning. So some institutes adopt OMA reserve for intraventricular injection of this chemotherapeutic drug, but the leakage and hemorrhage alongside the catheter with cancer drug, chemotherapeutic drug reflux is frequently observed. So from 10 years ago, our institute adopted solid chamber chemoport, and is very convenient to use as a continuous extraventricular drainage of CSF in case of increased ICP. Another problem is more than half of our patients have a CSF flow disturbance at the time of diagnosis, and it is a great obstacle to drug distribution. As you can see here, our drug distribution is greatly depends on the CSF flow between the CSF compartment. This is example of my patient. Up to 3 days after intraventricular injection, MTX is not diffused into the subarachnoid space, and patients can suffer encephalopathy as a side effect. To overcome this CSF flow disturbance, we developed the so-called ventricular lumbar perfusion chemotherapy 10 years ago. Simply speaking, it infused the drugs through this intraventricular reservoir, and the drug plus CSF mixed fluid is drained naturally via lumbar drainage. We set the daily administered MTX concentration 24 microgram per day through the phase 1 study, and we adopt a continuous infusion therapy. This is an example of both radiological and clinical response after ventricular lumbar perfusion chemotherapy. Patients can work from bedridden state. And we also performed the phase 2 study, as you can see here. This is very good for control of increased ICP, and limited to the non-small cell lung cancer patients, the overall survival is almost doubled. Another surgical therapy we can provide for this patient is CSF shunting. VP shunt is a well-known procedure, and recently I adopted the lumbar peritoneal shunt with a reservoir. In case the merit of LP shunt is we can continue our intraventricular chemotherapy via pre-installed OMA reservoir. I confirm that the drug infused in intraventricular reservoir is have us reached to the lumbar space in the lumbar LP shunt reservoir. I confirmed it with MTX level. And I summarized the 50 patients who received the cerebral spinal fluid shunts with the leptomeningeal metastasis. As you can see, a shunt procedure itself can almost increase the patient survival up to 7 months. So this is my summary for this presentation. Leptomeningeal metastasis diagnosis is currently made by CSF cytology, but to overcome the frequent negative result, we need new biomarkers such as metabolomic profiles. Intraventricular chemotherapy is currently considered as a standard therapy, and solid chamber chemotherapy is quite good for this purpose. In case of CSF flow disturbance, we can apply ventricular lumbar perfusion chemotherapy, and is very good for controlling increased ICP, and 70% of patients with increased ICP normalized, and it proved that almost doubled the overall survival in non-small cell lung cancer patients. In a future direction, every time possible, we can concurrently administer target inhibitor with this therapy, with this leptomeningeal metastasis, and we to develop more available drug for intra-CSF chemotherapy. And even simple CSF shunt procedure can make patients to go home and improve the quality of life and prolong the overall survival. All this our approach is cannot be made by neurosurgery department alone. With the help of oncology department and basic research department, work all together for this small improvement. So once again, congratulate your inauguration of the Pakistan Society of Neuro-Oncology and hope that your multidisciplinary work to help our patient. Thank you for your attention.
Faisal, you're mute.
Yes, so we thank Dr. Hoshin Guak for that very informative session. And we will now be moving on to the final presentation for this first session of the symposium, which is delivered by Dr. Edith Houston Warren. Dr. Warren is a professor of medicine at the University of Washington School of Medicine, a leader in global oncology, and head of the global oncology at the Fred Hutchinson Cancer Research Center, Seattle, a leading institute in cancer research globally. He is a renowned researcher who contributed to the development of adoptive T-cell therapy. Dr. Warren's efforts are primarily focused on cancers caused by infectious diseases that are preventable or treatable, making up 20% of cancers globally. He will be talking to us today on the primary and secondary lymphomas of the central nervous system. Over to you, Dr. Warren.
Thank you very much for that very kind invitation, and I want to congratulate the Pakistan Society of Neuro-Oncology on its inauguration, and I wanted to thank the officers of the society, and in particular my great friend Dr. Arthur Enam for the invitation to speak to you all today. I'm coming to you from Bainbridge Island, Washington, which is just outside of Seattle. And I wish you good morning, good afternoon, or good evening, depending on your time zone. And it's really a great opportunity. It's a great pleasure and honor for me to talk to you very briefly about primary and secondary lymphomas of the central nervous system. I have no conflicts of interest to disclose. The lymphomas of the primary of the brain, regardless of whether they're primary or secondary, are a relatively uncommon subset of all primary malignant brain tumors and CNS tumors. And in a large data set for the United States, almost 118,000 cases, lymphomas, both primary and secondary, accounted for about 6% of the CNS tumors. So relatively uncommon, but a devastating complication, and survival remains poor, as we'll see. And developing better treatments is an extremely high therapeutic priority. The lymphomas that involve the brain really come in two flavors. Those that arise exclusively in the central nervous system, we refer to these as primary CNS lymphomas, and those that arise either synchronously or metachronously with systemic lymphomas, and we refer to these as secondary CNS lymphomas. My suspicion is that in August and September of 2020, secondary lymphomas of the central nervous system are actually far more common than primary CNS lymphomas. But let me start with the primary CNS lymphomas. They're a unique tumor, an aggressive hematologic malignancy. They represent 4% perhaps of intracranial neoplasms. Early in the HIV/AIDS era, they accounted for 20% of all cases of lymphoma. But with the advent of highly active antiretroviral therapy, that number is far lower. They're highly associated with Epstein-Barr virus and immunodeficiency. They typically appear in the 5th, 6th, and 7th decade of life, i.e. patients in their 40s, 50s, 60s. Patients present with a variety of neurologic symptoms: seizure, headache, cranial nerve palsies, altered mental status, or other focal neurologic deficits. And they may also present with systemic symptoms, such as the classic B symptoms of lymphoma: fever, night sweats, weight loss, or diplopia, dysphagia, vertigo, and monocular vision loss. The diagnosis is made and requires brain biopsy. Imaging, of course, is also required. MRI typically shows ring-enhancing lesions in the deep white matter on contrast-enhanced T1-weighted scans. 95% of cases actually demonstrate homogeneous enhancement localized to the tumor with rare necrosis. And this characteristic is very useful in distinguishing primary CNS lymphoma from glioblastoma. The main differential diagnosis is cerebral toxoplasmosis, which is also common and prevalent in AIDS patients, and they also present with ring-enhancing lesions. Lesions are solitary in 65% of patients and multifocal in the remaining third. The cerebral hemispheres are the most common site of involvement, but other parts of the brain may also be involved. Magnetic resonance imaging plays a very, very important role in the staging and the management of both primary and secondary CNS lymphoma. In this set of images here, you can obviously see the tumor here in this contrast-enhanced T1 weighted scan. You can see the ring enhancement. In B here, this T2 weighted scan, you see the diffuse edema surrounding this large tumor. And sorry, this is the contrast-enhanced T1 weighted image right here. I would just point out that although most of primary CNS lymphomas are actually intracranial, there is the entity of intraocular lymphoma. Remember that the retina is an accessible part of the brain, and it actually is a rare subtype of primary CNS lymphoma. You can see it here on direct fundoscopic exam or here on ocular coherence tomography. The pathologic features of primary CNS lymphoma are indicated here. Here's a large tumor involving the basal ganglia and the parietal lobe. There's subependymal extension and invasion of the lateral ventricle with mass effect. There's angiotropic tumor growth, as is evidenced here. There's invasive growth along blood vessels indicated in this panel C. And there's robust expression of the oncogene of all oncogenes in primary CNS lymphomas, namely the MYC oncogene, which is demonstrated in this immunohistochemistry micrograph right here. Other histopathologic features, on H&E, you can see that the tumor displays a characteristic perivascular cuffing. These are B-cell lymphomas, and typically they are CD20 positive. There is typically a reactive CD3 positive T-cell infiltrate, and that tends to be perivascular. The presence of this reactive T-cell infiltrate is in some studies a favorable prognostic sign. The treatment of primary CNS lymphoma is essentially medical. That's one of the primary points here. Surgical resection is usually ineffective because of the depth of the tumor or the multifocality. Radiation therapy and corticosteroids can be palliative, producing partial responses. Unfortunately, primary CNS lymphoma occurs in more than 90% of patients. Median survival is but 10 to 18 months. High-dose IV methotrexate and leucovorin rescue may extend survival. Radiation is not recommended with concurrent high-dose methotrexate because of increased risk of leukoencephalopathy and dementia in older patients. Remember that this is a tumor of patients in their 5th, 6th, and 7th decades. Standard CHOP therapies are ineffective due to poor penetration of these agents through the blood-brain barrier. And anti-metabolites such as methotrexate and cytarabine, which cross the blood-brain barrier after IV administration, constitute the backbone of most anti-primary CNS lymphoma regimens with proven efficacy in prospective trials. Here's a flow chart that I won't go over in too much detail due to limited time of the management of primary CNS lymphoma from presentation to therapeutic decision ordinary clinical practice. Suffice it to say that after extensive evaluation, staging, baseline evaluation, consideration of prognostic factors, one does have to determine whether there's systemic disease, ask a question about treatment feasibility, define risk, and then come to a therapeutic decision. For those patients who are felt to be appropriate and suitable candidates for treatment, the histology of the tumor is important. For elderly patients and younger patients, high-dose methotrexate and high-dose Ara-C, as I said, are the mainstays of therapy. And these treatment algorithms indicate the subsequent steps in their management depending on the response. For those who are unfit for such aggressive therapy, whole brain radiation at 40 to 50 gray with steroid maintenance can be an effective palliative course. I talked up to this point about primary CNS lymphomas, those that arise in and involve exclusively the brain. But for a lymphoma doctor such as myself, what is far more common in my practice actually are patients with either synchronous or metachronous intracranial involvement by lymphoma in the presence of a systemic primary. And for all patients who develop systemic lymphoma, predicting the risk of secondary intracranial spread is paramount and of extreme importance. Much effort has gone into identifying the risk factors that identify patients who are at elevated risk for secondary intracranial spread. I've summarized here 6 risk factors identified by a group headlined by Norbert Schmitz, published in the Journal of Clinical Oncology in 2016. This group and these six risk factors define the CNS International Prognostic Index, or CNS-IPI. These risk factors are involvement of the kidney or adrenal glands, which is by far the most important, age, elevated LDH, ECOG performance status greater than 1, stage 3 or 4 disease, and more than one site of extranodal involvement. As I said, the most important of those 6 risk factors is involvement of the kidney and adrenal glands. We don't yet understand the basis, the biologic basis of the predilection for systemic lymphoma involving the kidneys and adrenals for secondary intracranial spread, but it's an incredibly important phenomenon and needs to be taken into consideration when treating patients and considering whether prophylactic treatment to the central nervous system should be administered. This finding was based on a study of over 2,100 patients by the German high-grade non-Hodgkin lymphoma study group, as I said, published in the JCO in 2016. The risk of CNS relapse by the number of risk factors in the CNS-IPI is indicated here. If all 6 risk factors are present, the cumulative incidence of CNS involvement is upwards of 30%, which is just enormous, recognizing that all 6 risk factors are present actually only in a small number of patients. The distribution of risk factors in that German non-Hodgkin, high-grade non-Hodgkin lymphoma study group is indicated here. The most common, obviously, were older age and elevated LDH. The kidney and adrenal glands was relatively rare, but it was of high predictive value. More recently, a group headlined by Klanova et al. Have shown that a combination of the CNS International Prognostic Index and a histologic feature of the systemic lymphoma, namely the cell of origin, or COO. I'm referring here to the phenotypic classification of the lymphoma as either a germinal center B-cell lymphoma, GCB, or an activated B-cell type lymphoma, ABC or unclassified, a combination of the CNS IPI plus the cell of origin can be a very highly and accurately predictive index for patients who are at risk for secondary intracranial spread. And those who have a high CNS IPI score and whose lymphoma phenotypes fall into the activated B cell subtype, as indicated here, have a 15% cumulative incidence of secondary intracranial spread. And for those patients, we typically recommend prophylactic treatment of the central nervous system with high-dose methotrexate to prevent secondary intracranial spread. So given the hour, I want to just summarize here and thank you for your attention. What the take-home points are and what I'd like you to remember is that lymphoma is an uncommon cause of a intracranial neoplasm. About 6% of tumors in the US, but it's incredibly important. And as I said, for a lymphoma doc like myself, it's paramount. Biopsy is essential for diagnosis. The treatment is primarily medical, not surgical. High-dose IV methotrexate and cytarabine are the mainstays of therapy. Intrathecal therapy plays at best a secondary role. Consolidation with high-dose therapy and autologous hematopoietic cell transplantation is recommended for select patients who achieve CR and have an excellent performance status. Unfortunately, however, relapse is very common, survival is poor, and research and better treatments are urgently required. And with that, I'd like to thank you for your attention and congratulate the Pakistan Society of Neuro-Oncology once again on its inauguration, and we'll be happy to take any questions.
Thank you very much, Dr. Warren. That was very insightful. And now we will finally be moving towards the question and answer segment for this session. We have reached an end to the panel discussion. We have around 15 minutes to take any questions that our participants have very graciously sent us. And for that, I would like to now invite the session chair, Dr. Noreen Mushtaq, to take over from here. Thank you.
So thank you so much, Faisal. So they are very good. There are some questions are very good. And one question is from Dr. Professor Shin Ovak. And it's, can leptomeningeal metastasis be cured? Dr. Shin, are you there?
No, Dr. Shin is not here.
He's not here. So we can, I suppose we can email
So
them.
I guess I can answer that question if you allow me.
Yeah,
So
sure.
so we don't know of any method that leptomeningeal carcinomatosis getting cured. Typically, whenever there's leptomeningeal spread of glioma or of any cancer, the life expectancy is the poorest. We're talking about 2 to 3 months. Not until and unless we come with some kind of a chemotherapeutic agent that infiltrates all those cells, there is no other method to deal with it. Radiation can't handle it, and surgery obviously is just to maybe open up the passages of CSF, and that's all. So the answer so far is no.
So there is another one for Dr. Warren. How is reactive CD3 proliferation associated with a favorable prognosis? Is this associated with cytotoxicity to tumor cells? Or CHOP therapy by intrathecal route effective?
I think I'll answer the second half of that question first. Therapy delivered intrathecally penetrates reasonably poorly into the parenchyma of the brain. Most primary CNS lymphoma is parenchymal. a high fraction of secondary CNS lymphomas have parenchymal involvement. So because intrathecally administered agents do not penetrate well into the substance of the brain parenchyma, CHOP administered intrathecally is not generally effective. That's a good question. I'm not sure I caught the first half of that question. Could you possibly repeat that?
You're mute, Dr. Noreen.
So how is reactive CD3 proliferation associated with a favorable prognosis?
Yeah, so as with many different lymphomas, it is very likely that the immune system plays an adjuvant role in the therapy. And just as there is likely a role for an immune effector arm that adds to the anti-neoplastic efficacy of chemotherapy, it is thought that the CD3 reactivity could represent an anti-tumor immune response. And so that remains highly speculative at this point, but I think that's the best guess as of September 3rd, 2020. Or September 4th, sorry.
Thank you, Dr. Mohan. There's another question for Dr. Mohan is, do HIV status evaluation, ophthalmological examination, and whole body PET-CT form essential components of staging of lymphoma?
Yes, I would, PET-CT imaging would be an essential component of the workup because CNS lymphoma is often detected in the presence of systemic lymphoma. And the management thereof will be very different. It would be highly important to to identify systemic involvement in anybody with suspected primary CNS lymphoma, because it would change the treatment approach enormously. Obviously, it would argue for a different set, perhaps a hybrid modified R hyper-CVAD type of regimen, which comprises alternating cycles of hyperfractionated cyclophosphamide, vincristine, adriamycin, dexamethasone with high-dose methotrexate and Ara-C, which address the systemic and the CNS components of the lymphoma.
Thank you, Dr. Warren. So there are a few questions for So there is a question, although it's for Dr. Eric, it's a recurrent medulloblastoma, 5 months after surgery. Parents don't want to redo surgery. Even after first surgery, didn't receive anything. What's your suggestion? So I can answer this. So if there is a recurrent MB, medulloblastoma after surgery, and parent don't want redo surgery, and he didn't receive anything, any radiation, any chemotherapy, so we have to tell the parents, we can treat him, but the outcome would be really, really bad. Because if this child comes to me, so my first plan is to do a redo surgery, and then followed him up with a high-dose radiation with concurrent chemotherapy, including vincristine or carboplatin as a radiosensitizer, followed by chemotherapy. But if they don't want a surgery, they can have the high-dose radiation, which would have a very bad effect in the child's growth, because I don't know, there is not any age mentioned in this, but for small children, a higher dose of radiation has a very, very bad outcome. But then if they don't have surgery, but radiation and chemo only, the outcome would not be more than 40 to 50%. So I think, so there's another question. Why is targeted therapy not so highly recommended? Dr. Warren, can you answer this? Why is the targeted therapy not so highly recommended?
So, so targeted radiotherapy or targeted chemotherapy?
It's the chemotherapy.
Yeah. So there are agents that both cross the blood-brain barrier readily and appear to have activity against CNS lymphoma. Probably the best example is ibrutinib, a BTK inhibitor, which readily crosses the blood-brain barrier and in some studies has demonstrated clinical benefit. Unfortunately, ibrutinib is extremely expensive wherever you are located, and it's a short half-life drug and needs to be taken on a daily basis, and for those reasons has not yet made its mark on the treatment of CNS lymphoma, although it's a component of a lot of regimens that are being evaluated in clinical trials.
So Dr. Warren, I have another question. So you tells us about adult primary CNS lymphomas. So I'm a pediatric neuro-oncologist, so although it's a very, very rare entity in pediatric age group, but I just want to know what is your experience of pediatric primary CNS lymphoma?
That is a great question, and I'll be very honest with you. My experience with pediatric primary CNS lymphoma is nil. I don't see pediatric patients, and I would love for someone to jump into the breach here and help me out.
Okay. So what we used to do is, as it's very uncommon in pediatric age groups, we used to have our regular chemotherapy regimen, which is NMB96 or the COC-based regimens, which including intrathecal, triple IT, including methotrexate, hydrocortisone, and cytarabine in these patients with a high dose of MTX. But fortunately, we have a better outcome, around 70 to 80% as compared to adults. So I think I have seen only one patient up till now, since I've started this neuro-oncology here at AKU since 2014. So it's pretty rare, but the results was excellent. So he came with this 5-year-old boy came with a GCS of 5, and then when he received the first IT and steroids, he was like up and about and jumping, like he had nothing. So pediatric has a great outcome.
Yeah, that's great, and I'm glad to hear that.
So there is another question. I think it's for Dr. Eric. So prognosis most strongly influenced by size and location of the tumor or the molecular subtypes. Actually, so I can answer this. So in medulloblastoma, yes, it depends on the size, of course, of the medulloblastoma, but location is not that important. And of course, the molecular subtype is very important, because in the recent classification and in the recent risk stratification, they have basically risk stratified medulloblastoma into 4 subtypes. The tumors which are Wnt activated has the best outcome. The tumor which have a sonic hedgehog, fully resected, TP53 wild type has a better outcome if they are non-metastatic disease, while those sonic hedgehog who have a TP53 mutant tumor has the worst outcome. And then group 3 with metastatic disease has a bad outcome, but group 3 localized disease is an intermediate outcome. And the 4th one is the group 4. So group 4 fully resected, it's an excellent outcome, while group 4 metastatic disease has a bad outcome. So basically, molecular subtypes is the way forward in treating medulloblastoma in pediatric age group. But there are other things as well, of course, the like age-old things, including the metastatic disease, the anaplasia in the histology. These are all, and the smaller the child, the bad the outcome. So these are the factors which are which prognosticate medulloblastoma in pediatric age group. So I think, Yes, so there's another question, Dr. Warren. Is there any role of radiotherapy in primary CNS lymphomas?
It is an approach that can be taken. I'm not a radiation oncologist. I think defining the most suitable field, I think, is challenging in primary CNS lymphoma, and I would just say from my experience that it's not typically pursued here at our center for patients who are unfit for high dose intravenous therapy with methotrexate and cytarabine. Whole brain radiation therapy can be considered as a palliative alternative. It tends to be fairly diffuse, even if only microscopically when it's detected. And so it's not really a curative approach in many patients.
Thank you, Dr. Warren. So, anything you want to say?
No, I was about to say you were muted, but you fixed that.
So there is another question, and I can answer this, is that, is there any way to diagnose early onset of medulloblastoma, or I would say early onset of brain tumors? So this is something which, you know, is very, very important in our part of the world as a low middle income country. So delayed diagnosis is one of the most common hurdle we used to have here. And if you go back, so there are various papers and researches has been done even in England. There is a Head Start program. And before that Head Start program, what they used to have, they have a period of around 3 to 6 months from the symptoms to the first evaluation of a child with brain tumor. So there is a lag of 3 to 6 months in England. So they have started this Head Start brain tumor program, and in which they included the healthcare basic physicians, primary physicians, pediatricians, healthcare workers, and they have developed small charts or tables for symptoms. And they have circulated those tables to various people and even to school teachers. And from that, when they have recruited their data, so they have found out that after this Head Start program of giving these small tables to the teachers, physicians, they have decreased this lag time to 4 to 6 weeks, rather than 12 to 16 weeks they have previously. So, so in our part of the world, again, we can have some kind of program like this. So we develop these kind of cards or things like that, or to circulate this to teachers and the primary healthcare physicians, pediatricians, neurologists, surgeons, to identify brain tumors early. Because in our center, where we do have a pediatric neuro-oncology, excellent teams and MDTs and a fellowship, but we still, previously we still have these kind of delays here as well, like a delay of 6 months and 4 months, and it literally affected your prognosis in pediatric age group, or I think in any age group for treating brain tumors. So I think that's all about for today's session. Thank you so much, Dr. Warren. Thank you, Dr. Eric, Dr. Ibrahim Kudumi, Dr. Numan, and there's one more. So it's an excellent session, excellent talks altogether. And over to you, Faisal. Is there anything else?
No, there's nothing. We've reached the conclusion of this first session of the first annual Neuro-Oncology Symposium. And I would just like to remind our viewers that the next session is today, the 4th of September, and it is going to start at 5 p.m. Pakistan State Time, which is around in about 7 hours from now. It is going to be chaired by Dr. Tariq Khan. We hope to see all of our viewers then for some more exciting discussions. Till then, goodbye and Allah Hafiz.
Thank you.
Thank you. Goodbye. Good night.
Thank you.
Can we stick on? Can we stay on?
Sure, sir.
Okay. Someone कहाँ है? Someone शहजाद चले गए ना?